Hi, everyone. Welcome. My name is Marilyn Shannon, and this is the Breaking Free Show. And I hope you're all doing well. Happy New Year. I've been off for a while, but I've been thinking about you. So I hope you're all doing well. Glad you're here. And I want to say hi to Amnon before we all get
Hello,
started.
Marilyn. How are you?
I know you miss me.
Boy, did I miss you.
It's been 2 weeks, and I heard the music and I'm like, wow, I like that music. Things never change.
It
You-
feels like you
It
were
feels
away
like I'm
for a
home.
year.
It does.
You
It's only
were.
been 2 weeks. I
It's
know, I know, I
it's
know.
it was
Oops, I know. You got
2019
me
last
there.
time. Yep,
You got me there. So you doing all right?
doing just fine.
Everything good?
Yep.
Good, good, good. Well, it's good to be back. It's good to be back with you all as well. And let me remind you, for those of you who may not know, you are welcome to call in anytime you want to this show. This show is here for you. Our phone number is 919-518-9773. And you can join us in our chat. Just put your name, nickname, whatever you like underneath the video, and you can comment, ask questions. We'll know you're there. And you can also come in on Skype, voice, not video. So don't worry. You just come in on Skype, computers, and that's plural, then the number 2K voice. And please feel free. This is an open invitation for you to come in anytime you want because we want you here. And we want you to ask your questions. We want you to comment. We want you to engage. And if you don't want to, that's fine too. Just sit back, listen, and just enjoy the show because it's going to be really interesting. So just remember, you are always welcome. So let me introduce my guest to you today, Michael Werner. Hello.
For you.
How are you?
Good. Thank you
Good.
for having me.
Good. It's a pleasure. I feel like I already know you.
Okay. You want me to
Good.
tell you a little about
I
myself and what
do.
I
Go
do?
right
And
ahead.
okay, so I'm very shy, as you can tell. So basically, I am a urologist. Went to Harvard, then UCSF, then did a fellowship. So basically, didn't finish my training till I was 34, which is a little ridiculous. But I only do male and female sexual dysfunction and male infertility. So my whole practice is devoted to that. And I sort of have a comprehensive slash holistic view. Um, Basically, we have a whole team that sees everyone, including nurse practitioners, a sex therapist, a nutritionist, and we really try to look at the whole person as we're doing this, but still using both a medical and a psychological model. So it's really the best job in the world. I've been doing it for 25 years, and it's just super fun.
So tell us, what is your overall philosophy about male dysfunctional, about sexual male dysfunction and all of that? What's your overall philosophy?
Got it. So there's a bunch of pieces to that. The first thing is that, I mean, if you think about it, sex is a little bit weird. Like, why is it so important that people have sex? But it is the foundation for an intimate relationship, for a partnership. Again, I'm going to usually use male, female, but my whole family is gay. I have what we say in Yiddish is gay yichus, because basically, we have trans, we have gay, we have lesbians. So, and my son is a well-known gay activist. But it's really, really important for an intimate relationship that people have sexual intimacy. It doesn't have to be intercourse, but they have to be doing things that they wouldn't do with their brother or sister. And I've watched this for years and years and years. And if people don't maintain that intimacy, then the relationship kind of implodes or explodes. So I think it's really, really important that that this happen. And the second thing is that I really want to normalize the dysfunction. It's very, very, very common. We'll talk about men, though we have a women's center for men to have erection issues. As we get older, we all lose our testosterone. As we get even older, it can become harder and harder to ejaculate. It's estimated that 30% of men have premature ejaculation, which most of them think is their fault. It's actually just the way they're built. And all of these issues can be and should be managed. So it's a very gratifying field, but the bottom line is, like, if we talk about erections, my mantra is, if you have a penis, we can get you an erection. Like, this is one of those fields where we can get you. Many of my patients have seen people who are not specialists, and then it takes them a lot of courage to go to the doctor. You know, you have erection issues. You think, oh my God, this is disastrous. It's so embarrassing. I've had people throwing up in my parking lot. You know, they're just so anxious. You know, and then they've gone to other people and then not gotten, you know, a good result, or spent a lot of no one spent a lot of time with them and figured it out. And then, you know, they're very discouraged and they leave it for another 5 years. And I find that very sort of depressing. But we really, really can make a difference, you know, in all cases. So it's
So,
very gratifying.
well, before I do have lots of questions, but the first piece I
Okay.
just want to say is to everyone listening, and I know our audience can be from, you know, the East Coast to the West Coast and around the world. Just know that, you know, Michael can see you, talk to you from anywhere in the world, and he does. So just keep that in mind. His what do you call it, a clinic? Do you call
Yeah,
your
I guess
facility a clinic?
it's a clinic always feels like it's sort of like, you know, a lot of people waiting in plastic chairs. But yeah, I don't
Okay.
really know what to call it. But
Uh,
yeah, our
uh,
center.
Your center.
Yeah, we have people who fly in from all over the world, and I like to feel like once someone sees us, they never want to not see us. So, you know, once we've been seeing people, they do come across the country pretty frequently to
And
see
that's an
us.
important fact. So tune in, keep listening because you're going to want to hear the rest. So first of all, what prompted you to focus in this area? What is it about
So
this? Yes.
yes, I've always, I don't really know exactly why, but I've always been obsessed with, you know, sexual function and infertility. Actually went to medical school knowing that I was going to do this. Couldn't really decide whether I was going to be a psychiatrist or an OBGYN or a urologist. And I sort of like the hands-on. So sort of, I do a lot of psychiatry, but I like to be able to do more hands-on stuff. So it's turned out to be heavenly. It was just a very long road for this particular topic, but I am obsessed. I mean, my family makes fun of me all the time because if I get into a cab, you know, I know exactly how many children they have. I'm always a baby pusher. I want people to have more kids when it's appropriate. I do what's called a no needle, no scalpel vasectomy, which is a very sophisticated way of doing a vasectomy that can be done in the office with really minimal pain, discomfort, sort of the standard of care. I actually have traveled internationally doing that. So I want people to have what they want with their families. And so I'm sort of obsessed with that. So it was really a natural outgrowth of my personality and interests, sort of in an unusual way.
No, well, it's interesting for everyone listening because one of the first things you were asking was, about our families and, about our children, grandchildren, all of that, and I thought, well, that's interesting. And so you just what is it all about? Love? Is it about what is it about? Connection for you? What's it about? You
Yeah, I
as a
would say
person.
love and family. You know, I'm just I come from a family where like a lot of children were lost, and so there was always a feeling that you wanted to have more children around than there were. I think it's one of the reasons why I started we have a cord blood bank, which actually is a service that people can use nationally, almost internationally. That's where you take the blood from the placenta after the baby is born. You process it. It can be frozen, and then God forbid they get, a blood disorder, then it can be, given back and can be life-saving. And so there's a lot of cord blood banks. We're just one of the best and the cheapest. So I really want to make it accessible financially. But I think that sort of permeated sort of who I am.
Wow.
Um,
It's amazing, really. I got the chills.
yeah,
Yeah, I
yeah,
got
it's
the
sort of fun
chills.
to do exactly what you're passionate about,
Sure.
So I never want to retire. Like my wife and I get along very well. It's been 34 years, but her mantra is forever, but not for lunch. So because I get what are called spilkas. Like if I'm not working or doing something productive, I am not a happy camper,
I hear you.
and I really do love going to work.
I hear you. So tell me, is there a theme that you're noticing for the dysfunction or what? Is there some kind of a theme you're noticing for the time? Is there a medical theme? Is there an emotional theme? What are you seeing?
So yes, yes, and yes. So I think what's one of the most important themes for we'll talk about the men. That's going to be the basis of today's discussion.
Right.
We do have a center where we see women with sexual
And
dysfunction.
hold on a second.
Uh,
We did do a show on women's dysfunction, and you will find that replay on our YouTube channel. And it's very interesting. And if anybody has any questions about it, just reach out to me and I will guide you. And then Batsheva, who works with Michael, was on our show and talking about women's, sexual health and well-being. So we have that for you as well. Just know that. But today we want to focus on the men. So go ahead.
Yeah, so actually, I'll take a little segue because it's just coincidentally this morning I did do some of the procedures for what's called vaginismus. We are actually probably one of the world centers for vaginismus, and that we do have people fly all over the world. In fact, today we had someone from South Carolina, you'll be pleased, and we had someone from Florida and someone from Indianapolis come in. And vaginismus is where a woman clenches involuntarily the muscles of the vagina so tightly that nothing can come in. So they can't put a tampon in, they can't have intercourse, obviously, they can't have a OBGYN exam. And it used to be sort of incurable. And actually, a Holocaust survivor came up with the idea and then sort of turned it over to us. And we bring them in, we put them under anesthesia. They're tight even under anesthesia. It's really remarkable. And then we dilate them up gently, and we actually paralyze the muscles temporarily of the vaginal wall with Botox. And then we teach them how to put a dilator in and out. And by that time the Botox is worn off, the vast majority of them are able to have intercourse. So it's really a game changer. We had a woman come in from Vietnam, and she actually had a child, and the way she actually conceived was they had dripped the sperm on the outside and had gotten in, and she got pregnant. And even after she delivered, though, she couldn't have sex, and so she was successful. She started having sex at 45, even though she had a daughter in her 20s. So it was pretty amazing. So that's the vaginismus. But going back to the men, I think one of the overarching important ideas that people have to understand is that sexual dysfunction, or just having problems, we'll just do the simplest one, erection issues, is a natural part of aging. If you live long enough, you will almost invariably have erection issues. I have 4 boys. That's where the name Mays comes from, Matthew, Adam, Zach, and Evan. And when I teach their high school classes, I always take the seniors and talk to them about sex, and I look them in the eye and I say, all of you in this room, at some point, as inconceivable as it is to you now, will have problems at some point with erections. And just know that that's just like a normal part of aging, just like you're going to need reading glasses at some point. And don't get all, shocked about it. Don't get so upset about it. Don't deny it. Just manage it, because we can always manage it. And that's the nice thing about this field. And then, of course, it is a combination many times of a physical and a psychological issue. But I think people are very quick to, especially with younger patients, to say, well, you're only 30, so this is probably mostly psychological. So go see a therapist, and that'll cure it. So we will always do an evaluation because a certain percentage of these men will have a primary physical problem. We will always have them see our sex counselor and advisor to sort of get a background history. But we will usually sort of attack it in both ways. And often, if it becomes its own loop, so you're not getting a good erection, then you get really anxious. Then, of course, the next time you fail. So sometimes, even when we figure out that it is anxiety, we'll try to treat the anxiety, but we'll also make sure that they get an erection. We'll sort of blast through it, and then often it'll just disappear, which is lovely. So it's very gratifying.
It is. So what do you notice, what happens with a man once they are, healed? What happens to their personality, to their, just how they feel about things? What do you notice?
Right. So men are obsessed with their penises, and they're obsessed with their ability to have intercourse, the vast majority. And so it does an amazing number, in a bad way, on men's self-esteem and on their interactions with their partners. We find a really bad dynamic happens. Men start having problems with erections. So let's say they're married to a woman, and then what they do is they start becoming less affectionate because they're afraid if they give their wife a hug, then that's going to lead to something. And so they're pulling away. And women, in my mind, are much nicer than men. And women will often then take it on themselves and they'll say, like, oh my God, he's not finding me attractive anymore. Maybe he's having an affair. And so then they're feeling badly about themselves and the way their partners are feeling about them. And it becomes this terrible cycle. And so it really just tears a relationship apart. So we find that we really need to get them back into intimacy. I'm always tell the guys who put off coming for about 10 years that we're going to get you great erections. Your wife is going to be thrilled, and then she's going to be really angry at you for being such a goofball for putting this off for 10 years because you put both of you through hell for really no reason. And we see that all the time. It's like they're grateful and they're like, what the hell were you thinking?
Right.
So because women interact with the medical system much more intelligently and frequently than men. I was approached actually by the county of Westchester, which is where I live, north of New York, and they were saying that the best way to get men into the health system is through sexual function. They can be having heart attacks or strokes or things like that. They're much less interested in treating that than they are their erection issues.
Interesting. But it's great. Your personality is great because you make this seem like, on some level, no big deal, and people need to feel that.
Right. Right. It's just like if you go to I always use the reading glasses. If you go to the ophthalmologist or optometrist because you can't read a book anymore, then no one's going to look askance. And that's the way we sort of look at this, young or old. This is going to happen to a lot of people. One of the most common things we see is premature ejaculation. We think that 30% of men have premature ejaculation, and can be defined differently, but basically, the formal definition is if a man penetrates into vagina, it could be an anus, and ejaculates within less than a minute, then that's premature ejaculation. I think that's a little strict. To me, if a man's spending the whole time once he penetrates saying, please don't come, please don't come, please don't come, then, obviously that's taking a lot of the fun out of it. And that's something we can always manage. And a lot of people feel very guilty about it and badly about themselves and wonder, was it the way I learned how to masturbate? Is it unresolved feelings about my mother? It's really just the way some people are built, just like some people have faster reflexes and slower reflexes. And so we just have to slow them down.
And so you help, it's kind of like you're teaching them how to have sex.
Yeah, in this case, what we do is we need to, since it's medical, sometimes we have to put them on medications, we have to put them on numbing agents. We can get them erections that can last through the ejaculation. So there's many different ways of treating this. But it definitely needs to be managed because, if there's this whole buildup and then you're inside for 30 seconds, especially if you have a partner who reaches an orgasm through intercourse, then it's very frustrating for both of you. So that's something we can always manage. It takes patience, but we can always do it.
So what has been a case that, and this could be private, I don't know if you talk about it specifically, that might be something you can't do, but can you give us some ideas of some of the types of cases you see?
Well, our favorite cases are the guys who come in and really their life sounds terrible. Their lives are a mess, and they come in and they're not engaging they're afraid to start a relationship because they're not getting good erections. One of the main reasons that they started not getting good erections is anxiety or social anxiety. They may have a very low testosterone, so their libido and their interest is low. They may have ADHD on top of all this. So for us, when they come in, and especially if they're a lovely person, we look at them and we're like, oh, this is a fun project because we are going to totally turn around this guy's life. At their first appointment, they filled out a bunch of questionnaires. I think, I mentioned it. We'll look at their nutrition. We'll look at their sleep patterns. We'll look at anxiety and depression. We'll look at their erections. We'll look at their nutrition. They'll meet with our nurse practitioner. Then they'll meet with me. We'll sort of come up with a game plan. They meet with our sex advisor and our sex counselor. They meet with our nutritionist. We do our evaluation. We sort of figure out what's going on. And then we try to treat all of these different pieces. And so it's a game changer for a lot of these men. And that's very, very gratifying. And you feel sort of like you've gotten them on the right track. And I don't mean to be, conceited, but I don't feel that almost anywhere that I've ever seen marshals all of these resources with really, really good people to sort of address all of the problems that come up.
I bet
So
they come in looking kind of ragged, and then once they've come through some of this stuff, they begin to look dapper, and they start feeling better about themselves.
Yeah, well, if I could make people look dapper, I would have done that to myself too. But so
tell me something
dapper
about
is,
Tell me something about nutrition.
So the key with nutrition is think about getting an erection. In order to get an erection, a man has to get the blood into his penis and he has to hold onto it. And think about the blood inflow. It's just like you have to get good blood flow into your heart so that you don't have a heart attack or a stroke. So anything that is going to make you more likely to have a cardiovascular event, like a heart attack or stroke, is going to be more likely to give you erection issues. So the classic ones are smoking, high blood pressure, diabetes, high cholesterol, inactivity, not exercising enough. So all of these things will make you more likely to have erection issues. And in fact, there's data that shows that if you develop erection issues in your 40s, you are 50 times more likely to have a major heart attack or stroke than someone else your age in the next 5 years, because it's like a harbinger. It's like the first sign of some vascular problems. So it's really very motivating for people when they see that they're getting erection issues to start taking better care of themselves. So I'm a great believer in the cholesterol medicines, the statins. And many of my patients have come in having been told by their doctors to go on a statin, and they're like, I don't like being on a pill, and it makes me feel old. And then I say, that's fine, but that's why you have the erection issues. And if you don't take good care of yourself, you're going to have a heart attack or stroke in 5 years, and they're much more willing to listen to what we have to say.
Absolutely. And then having sex makes you feel young.
It does.
It does.
Yes. It's
it
good
makes
exercise
you feel.
too.
Yeah. Uh-huh.
Yeah.
So, and then go ahead.
Yeah. I mean, one of the other main things that we treat are men with low testosterone levels. And so it's amazing how much we are dependent on our hormones in terms of our functioning. So a low testosterone can make men have a low libido. It can affect their erections, but only modestly. It can give them difficulty getting, putting on muscle and taking off fat and even getting themselves to exercise. And it can absolutely decrease their energy levels. And so when men come in and they have symptoms and a low testosterone, we're very actually aggressive about putting men on testosterone. It's really important to remember that if you take testosterone from the outside, it will shut down, at least temporarily, sperm production. So it's important that men who still want to have sperm either use different medications than testosterone or bank their sperm. We do have a sperm bank. But I think the 90% of the men who have symptoms and a low testosterone, when we treat them aggressively, will notice dramatic improvements in the way they feel. And again, if the normal is like 300, we're not aiming for 400 or 450, we're aiming for 700, 800, 900. And then over the course of the year, they will feel dramatically better.
Interesting.
Yeah, there's a lot of fear about testosterone. People are worried that it's going to increase prostate cancer.
Mm-hmm.
That was in the books a long, long time ago. But I can tell you that they've completely disproven that theory. And in fact, if a man comes in and he has diagnosed prostate cancer, and my office, of course, is in New York City and then in Westchester County. So I work a lot with Sloan Kettering. And they can have diagnosed prostate cancer and be on a surveillance protocol where they're watching them, and they're completely comfortable with us putting them on testosterone. So it clearly does not exacerbate or create prostate cancer. And the second thing is men are worried that it's going to cause heart attacks or strokes. But there was the best paper out there came out. It was a Kaiser paper looking at 22,000 men with low testosterones. And they put 8,000 of them on testosterone, and they followed them for 3 years for all cardiovascular events. And guess what they found?
What?
It actually decreased the heart attacks and strokes by a full third. And the reason is, I don't think the testosterone itself is having effect on the blood vessels, but if the men are on testosterone, they have more energy. they exercise more, as you alluded to, they're happier, they feel more vibrant, they just change physically and psychologically, and that has a huge effect on them. So I
Right.
think testosterone is really underused for a lot of men who could benefit from it.
Well, it appears to me, and I'm not a doctor, and I'm far from a doctor, but it appears to me that you're learning. I mean, you're an innovator, and you've got to be learning just from the people who are coming in and from your own practice, because there's not that much out there that you can connect things to like you are, like you have to be.
Right. I would say that I am an early adopter of
Hmm.
things when they're good. My father was a physician, and he always said, don't be the first to use a medication or treatment, but don't be the last.
Mm.
Like once something's new, don't jump on everything, because a lot of things turn out to be, flashes in the pan and even dangerous. But
Right.
don't be a stick in the mud. And if it's good, then use it.
Use it.
So I would say where I am most innovative most of the time, there's other things that we've done, is by just sort of the way we've set things up so that patients get a huge amount of time and a bunch of different people looking at them in different ways, so that we get a comprehensive picture of what's going on. And then we will meet as a team, and discuss, how we best want to work with this patient. And I think that's where I've been more innovative. I
Right.
will say that there's two things that I'm very proud of that we actually have been very innovative in. So one is with male infertility. So there's about 15% of couples will have problems with fertility, and about 50% of them will be from a male factor. And then about 15% of those men will have actually no sperm in the ejaculate. Um, and one of the things the way we approach that, it's pretty interesting. But once you've maximized their sperm production and figured out what's going on, there was a technique originated in Israel, where you actually take this, some of those men will actually have very, very, very low levels of sperm production, but you wouldn't see it in a typical semen analysis. So we can actually spin it down. We spend 5 or 6 hours looking at it underneath the microscope, and isolating individual sperm and freezing them on a special like tray that the Israelis created. And each one of those sperm can then be injected into an individual egg, with ICSI, and babies can come from men who really look like they're not going to have any sperm. So those, we have people starting to fly in from all over the country. We call it the extended sperm search and microfreeze. You
Wow.
know, so that's pretty cool. Yeah.
Yeah, it is really
So
cool.
that's really cool.
Yeah.
Yeah. And the other thing that's really interesting now, which I did not create, is there's something called, we've never been able to sort of cure erectile dysfunction, but there's something called low intensity shock wave, which is really like a pressure wave that we can use on the penis. Most people have heard of, like, where you use a shock wave to break up kidney stones.
Mhm.
It's like this, you go into a bath, and it's a very intense shock, and it isolates, it goes right onto the stone, and breaks it up. So that's high intensity shock wave. And there's something called low intensity shock wave therapy, where we can actually put it on the penis, and we know that that brings blood flow into the penis. And it's not been FDA approved, though it's used throughout the world. It's been approved in China and India and Israel and Europe, and they are going for approval here. And it can actually, at least long term, if not permanently, improve the blood flow. So we've gotten some men off any interventions by using
But
that.
how long
So
does
that's pretty.
something like that take to be approved here?
You can do it without approval. The nice thing about your MD degree is you can sort of do almost anything you want on any patient. You just have to make sure you're doing the right thing,
Hmm.
because it'll catch up
Right.
with you.
Oh, they, huh?
So,
Yeah.
I do have the machine, and I'm doing it. It could be a while till it's FDA
Right.
approved, and just because it's FDA approved doesn't mean that insurance companies are going to pay for it. So those are two
Right.
different steps. But
Exactly.
we've made it, very reasonable, because it's really quite easy to do,
Exactly.
actually.
Now, you also
Yeah.
mentioned sleep, and sleep's a big issue for a lot of people. So, how does that enter into the picture?
So it is a big deal for a lot of people. And I would have to say, of all the things that we do, I like to be able to help everyone on everything. And sleeping is still this big sort of closed unknown. And I mean, there's obviously sleep physicians who are really spend their lives with that. And we have patients who just cannot get a good night of sleep. But we're often at the very beginning of this. And so a lot of men will come in with what's called sleep apnea, which
Right.
means that they are not breathing correct, they stop breathing for long periods of time and they're not getting enough oxygen when they are breathing. And we know that can affect erection issues as well as, of course, daytime fatigue and have a lot of overlap with the symptoms of low testosterone. So we actually screen them for sleep apnea. That's one of the questions. I'm glad you brought it up. That questionnaires that they fill out at the very beginning. And we actually have some portable machines that they can take home so they don't have to go to a sleep lab that will screen for the sleep apnea. If we do find that they have sleep apnea, first of all, if they lose weight through going on the testosterone and exercise more, that will disappear. Sometimes it's weight and age related usually, and if not, then there's machines that they can wear at night, and it can be really game changing for them. And that we will send them out to a sleep specialist, but it's a really important piece.
Mm-hmm.
Now, a lot of men, again, sleep can be related to what's going on with them psychologically. So we have a lot of men where we diagnose that at night, if you're one of those anxious people, that's when your anxiety comes out. You get anxious, you're ruminating, you're going over the same things, throughout the day. And so we will put them on antidepressants, anti-anxiety medications, which will sometimes help with the way they're approaching their erections and their social anxiety. And then a lot of them will say that they're sleeping dramatically better as well.
Wow. There's a lot to this. So now tell me, do you work with gay men too? Gay and straight men?
Oh yeah. I would say we have an office in Manhattan, and I have really tried to make it clear that we are gay friendly. If you think it's hard to go to a doctor with erection issues, now imagine you're a gay man going to a straight doctor, and talking about erection issues. And unless you know in advance that this is someone who's going to be comfortable with this, it's really can be very intimidating. And I did start this 25 years ago. And of course, thank God we've come so far, in gay rights and gay liberation and people being comfortable with themselves and other people being comfortable with them, that it's a different era. But
Right.
I've always, of course, been comfortable with this since every other person in my family is gay. And it's so obvious that this is just who people are,
Oh, and so you have a son that's gay. So
I do.
So
Yeah.
so and he's so it's interesting that all the pieces kind of play out together.
Yeah, it's not actually. I would have to give my wife more credit for his activism. She was one of those activists from way back. She worked for Soviet Jewry for a long time, and there was not a rally happening anywhere that she did not take the kids to. And so he created. I'm very proud of him. His name is Adam Eli, and he created an organization called Voices For that advocates for queers in trouble anywhere in the world. This is sort of a non sequitur, but there's a Jewish principle, and I'm clearly Jewish, that that Jews have to take care of each other. And he said, well, queers are not doing that, and so he sort of brought that Jewish consciousness into gay activism. And I think he has like almost 70,000 followers, and he speaks internationally, and he has a book coming out, and it's pretty cool actually.
Well, maybe he would like to come on our show.
I'm sure he would. No,
yeah, I would love. Yeah, that'd be kind of fun.
He's charming, and I'm biased, but he's really one of the most special people I've ever met.
Well, that would be wonderful. I'd love to have him on. If he's interested, just let us know. Yeah, that'd be great.
Indeed. Thank you.
Yeah. And what are the stories? I don't know how to even put that, but a gay man coming in, are they having similar stories as a straight man?
Yeah, it's often very generational. So we get the older gay men, many of whom were married to a woman, and realized throughout that they were gay, but this is sort of what was expected of them, which of course means that they're much less interested in having sex with their partner, since that's not the partner that really they're attracted to, and often so they've had sort of a long-standing sort of suboptimal sex life. They're not always. It's really fascinating, and now they're sort of new at this, and by the time they're exploring this. They could be in their 40s or in their 50s, and their erections aren't as good, and they're already anxious to start with. And if they're going to be a top with anal intercourse, then of course I think they have to be even more rigid to penetrate through an anus than a heterosexual man has to do getting into a vagina. So it's a lot of pressure on them,
Right.
as well as a learning curve. So we get those, and then we get our. It's still difficult to be gay. It's still not the same, and there's still, at least like my son's generation, so he's just turned 29. They're still 5 years behind their peers in terms of their romantic lives because they didn't play around that much in high school, most of them, and they didn't have crushes, and so we find that their experience levels are can be less than the average heterosexual man. And also, there is a lot of body issues
I was going
in
to ask you
general.
about that. I was,
Yeah,
yeah. Go ahead. I'm glad you're bringing it up.
yeah, yeah. I mean, men and women both. I mean, men are very visual, and so which is, I think, one of the reasons why particularly women have so many issues with body dysmorphia and anorexia and bulimia. But if you're a gay man, so then that you're very visual, and that the person you're sexually attracted to and hoping to have sex with is also very visual. So if you're not right now, it's very fat is not an acceptable, any fat is not, the way to look. And so there's a lot of body dysmorphia and people feeling badly about themselves and almost unentitled, to have sex if they're not skinny, 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 or muscular, muscular, muscular. And so we have to sort of break through that a lot. So we do find that a lot of these issues are magnified, in the gay men. But I don't know. To me, they're one of the groups that I most love seeing, and the easiest in some ways to make a difference for.
And why the easiest?
Oh, I'm sorry. So they need a lot of work, and a lot of they need a lot of compassion, and they need a lot of us feeling comfortable with them, which they never know is going to be a guarantee when they walk in. They need to be sent to the right therapists who are going to understand them. So we need to sort of troubleshoot all of the issues. Look, and some of them have really been rejected by their families and are out there on their own. Some of them, are then turning to substance abuse because they've just had such a hard road. So, my heart really, just based on my own experiences and my family, and just because if you're a nice person, like they've just had a harder time, and so they deserve our help, and they're really a pleasure as a group.
Yeah. Yep. I agree. Yeah, go ahead.
One of the things we haven't really talked about is men with Peyronie's disease, which is a very common thing that we see. So what Peyronie's disease is when men develop a bend or twist or curve to the penis. There's been commercials on TV now. So it's like a scar tissue of the actual lining of the chambers of the penis. And it can happen suddenly, or it can happen after they've had some kind of trauma with intercourse. And so that they can get this curvature of the penis, which can be so extreme. It can be like 90 degrees to the point where they actually can't penetrate, a partner. And the nice thing about that is that in the last 5 years or so, there is a new medication called Xiaflex that we can actually inject directly into the scar tissue, and which has a pretty good success rate of dissolving it so that we can help straighten out the penis.
Wow.
It's when I promised any man who walks in, I said, if you have a penis, we can get you an erection. We're always going to get them erections. With the Peyronie's disease, the Xiaflex does not always work. Unfortunately, I like everything that's sort of a guarantee. But if we do it and it doesn't work, then I will send them to a real reconstructive specialist, and they can get it fixed surgically. But most people always prefer to have it a non-surgical intervention rather than a surgical one. So I would say with that, it does take a lot of finesse to get the medicine in the right place. So if a man has that problem, I'm obviously not the only one in the country doing that, but they should really, really pick a urologist who has a lot of experience in this particular area, because you'll just do much better.
So I want to just remind everyone, if you're just tuning in or whatever, great thing about maze, one of the great things that I'm learning, is that a man and a woman, or a man and a man can be, or a woman and a woman can go together. I mean, because in very often it could be a couple thing, right? Maybe not just the male thing or the woman, but both of you need to
Yeah.
be worked
No,
with the same time. And here's an option,
right. So
right?
it's really the fun ones. And this really is fun. So I keep saying that, but the fun ones are when the couple comes in and they're both, I mean, it sounds terrible, but they're both having sexual dysfunction. Why is that fun? Is, well, we have the women's center and we have the men's center. So I'll give you a couple of examples. So we had one couple where he had erection issues, and that was what they'd recognized. But then once we managed the erection issues, we realized that she had what we call vaginismus. So he was getting this erection, but every time he tried to penetrate, it was like hitting a brick wall. And so we then treated her for vaginismus. So, you need an erection, you need a vagina that can actually at least, hold a penis or get a penis inside. And so
Right.
we treated them for both. And they had come in because they were actually more interested in having children than they were in sex. But obviously we got them within a very short period of time able to have sex, and I think they had a baby within a year of starting to see us, and so
Wow.
that was very gratifying when you're hitting both sides. The other ones I really like are the women who are having orgasmic problems, who are married to men who have either erection issues or premature ejaculation. Well, that's not a match, and they sort of look at this problem. It's like, oh my God, where do we even start? And so we'll often refer one clinic to the other. We're all under the same roof, and so you're working on her having libido and being able to reach an orgasm, and you're working on him being able to get an erection or not having the premature ejaculation. So the synergy, it does take two to tango.
It
That's our
really
goal.
does.
And so, yeah,
And
so
it
you
could be
need
a
to
lot
sort
of
of,
things, right? There can be so many issues that can cause
right.
these
So on
issues.
the men's side, right. So on the men's side, they could be having erection issues. They can have premature ejaculation. They can have Peyronie's disease. They can have a low libido from a low testosterone. They can have depression. So they can have all of these things. And the women are even more complicated than the men,
Right.
and they can have low libido. They can have arousal problems. They can have pain with intercourse. They can have orgasmic issues. And so. If we're not handling all of those, then they're really going to have a suboptimal sex life.
And how many people actually work in your centers?
Oh, it's a lot.
It's a lot, huh?
Yeah. So so we have the men's team, um, and that's headed by me, and we have then two nurse practitioners. We have a sex therapist. We have two medical assistants, and we have a nutritionist. So that's all, and an exercise physiologist. So that's sort of on my side. And then we have the women's center, and each woman is seen by a therapist, as well as a nurse practitioner or a PA. So we have three teams of those. And then because I do infertility, we do have a lab that does a lot of semen analyses, and we have one of the big local sperm banks. So when I say we have a sperm bank, it's for men to use for themselves. It's not like a donor sperm bank. It's
Right.
again, we're near Sloan Kettering. We're near. So if a man is going to be undergoing like a procedure where he's going to have his production or delivery of the sperm threatened, then we'll bank the sperm, in advance.
Okay.
That can be testosterone, that can be chemotherapy, that can be surgery, and then we also have the cord blood bank. So we have a bunch of different pieces. They're all sort of very interrelated, obviously.
I wonder, do you have any questions on that? As a man listening to this? No? I'm just curious. All right. Anybody out there? If you have any questions at all, 919-518-9773. This is your chance. Computers 2K voice on Skype. And you still have time to enter into our chat and ask questions there. And we'd love to hear from you. Comment, ask questions. If you've had any experience in this area, you do not have to give your name, but share your experience. We'd love to hear from you and, learn from you. So how does menopause affect men?
Menopause.
Yeah,
Well,
women's menopause.
yeah. So, I sort of, again, this is a little bit controversial, but I'm not sure that women should have to go through menopause. It's like sort of like if I told the average man that you're going to lose all your testosterone or that your testes are going to shrivel up and disappear, they wouldn't be so accepting of this. But assuming that a woman goes through menopause, often their testosterone levels are by definition dropping, and often they will have a lower libidos, not everyone, obviously, and they will and women needs estrogen in order to keep the vagina lubricated and moist. And so then they have what's called atrophic vaginitis, where basically it's uncomfortable and painful when they're having intercourse. So we definitely want to manage the symptoms, of women with menopause. So we have a lot of women that we put on testosterone replacement therapy. It's very interesting. There's a laser. It's very counterintuitive that you can actually use in the vagina. The one we use is the brand is called the Mona Lisa, and what it does is it sort of burns off, the layer of skin in the vagina, the epithelium, and when it heals, it actually is plumper and more like what they had before they went through menopause. But I sort of see women as going through menopause as the same thing as men. Menopause means sort of like going like this, and then it stops. So women are sort of falling off a cliff slowly, whereas men are sort of going downhill slowly. And so at a certain point, most men will reach the point where their testosterones are low enough that they're noticing that they're symptomatic with, decreased energy, libido, muscle mass, erections. And a lot of people will say, well, it's a natural function of age, which is true. As we get older, our testosterones get lower. But that doesn't mean I find that a foolish argument. Just because it happens with age doesn't mean we have to live with it. Cholesterol levels go up as we get older. High blood pressure goes up. We don't just say, oh, you have a high cholesterol level. And, a lot of old people get heart attacks and strokes. So that's just what it is. We try to manage it. And so as men get older, if their testosterones are getting lower, which they are, but if they become symptomatic, we don't have to assume that it's just from getting older. We should manage it and manage it aggressively. It's really dramatic when you see the men in their 70s who are being treated with testosterone and the average one who is not. It's really, it's hard to conceive.
Right. And I think just even having this conversation, I'm sure that there's so much more to talk about. And if I was a doctor, we'd be having on a different level. But the point is just hearing this conversation for men that are out there, women that are out there listening that can, guide the men in your life to something like, listening to the show and whatever. I think that opens up a whole new world. So many people hide from things.
Yeah. We do find that a lot of the time it's the women who do the research and finally, tell their partners, husbands, whatever, that they have to come in.
Right.
And it's amazing how long some of the men will resist. And I always find it's sort of amusing. If the man's put it off for too long and then comes in, first of all, I tell them, I look them in the eye and say, like, I'm going to get you erections, then often they'll start crying, which is sort of charming. And then they don't really believe me till I've done it. And, I've done this enough times that I sort of know the difference. But I warned them in advance, if they've waited a long time, it's like, your wife is going to want to kill you. She's going to love the fact that now you've been managed, but she is going to be so angry that you took so long. And you just have to suck it up because she's right and you're wrong.
Right.
And you should have come in a lot earlier. Mm-hmm. And eventually, you'll reach an equilibrium.
So,
one of the things
Go ahead.
Well, I wanted to talk about the different treatments for erection issues, because I think that a lot of men, in fact, most men and most women, don't really know what's out there. So when I opened my practice, which was 1995, that was before Viagra, which came out actually on my anniversary in 1998, and before the internet. So the men really thought that they were alone. If they had erection issues, they thought they were the only people in the world. And they thought they were just so bizarre and cursed, and something was fundamentally wrong with them. With Viagra, that opened the door. And then Bob Dole, of course, started talking about it. And really, men sort of realized not only was this common, but there was something they could do about it. Mm-hmm. The problem is that many men don't respond to that group of medicines, which are called the PDE5 inhibitors. They are in order: Viagra, Levitra, Cialis, and Stendra. And first of all, many men take them incorrectly, which we'll talk about in a second. But even then, many men, even if they take it correctly and at the maximum dose, are not going to get and maintain good erections. And then, of course, they feel like they're doubly screwed over. Like they went, everyone else is responding, no one else has the problem. They go, now they're taking the pills and it's not working. And so, but again, we can get, anyone good erections. The most if the pills are not working, even when they're taken correctly, then my favorite technique to use are what are called the penile injections. So I can sort of feel Amnon putting his hands over his crotch as we speak. And basically, they sound terrible and they're amazing. So what happens is, what the man is doing is he takes a device, it's called an auto injector, puts a 30 gauge needle, teeny, teeny, teeny needle, into the auto injector, presses the button, and it gives an injection into the side of the penis, into the erection chambers. It does not hurt, which no one believes me. It feels like you've been flicked with a rubber band. And what we're doing is injecting medication directly where the man needs it to cause an erection. And that works in almost all men. Certainly 85% of the men who come in where the pills are not working. And those men can get absolutely extraordinary erections. In fact, actually, most of the men who are doing porn are using these injections. And that's why if you ever see porn, a lot of these men go, I mean, literally, if you were to count the thrusts, it's like in the thousands, which is physiologically impossible before keeping the erection and ejaculating. And then they keep the erection even after the ejaculating because they've used the injections. So I think it's really important for the men to know that if they have failed with the pills, first of all, go back and make sure you're taking it correctly. And second of all, think about the other options. And there's, of course, injections, there's a vacuum pump. And for some men, because again, you have to get the blood into your penis and you have to hold on to it. If they have a trapping mechanism, if they have a hard time holding on to the blood, sometimes nothing but a penile prosthesis is going to work. And that's an implant. And the men love, love, love them. So I don't happen to do them anymore because most of my men don't need them. And I'm an obsessive perfectionist, so I sent them out. But the men do love them. And if you go to someone who doesn't, who sort of decides whether you need one and then go to the place where they do them really well, it's a really great intervention, which is the main reason why we can say that we can get an erection for anyone.
And masturbation. What do you tell men about masturbation? Or what do you tell women about masturbation?
Yeah, so let's talk about the men for a minute. So first of all, it's completely a normal thing to do. And it's really important that men learn how to masturbate at an early age. So that's one. Because if they don't, then it's actually can be hard to learn how to ejaculate later. So it's really, really important. What we do find, interestingly, is that we have a group of men, and this is not uncommon, who walk in and say, my libido is low. I just don't want to have sex with my wife that much. And so when my next question is, well, how often are you masturbating? And they'll say, I have a low libido, but I'm masturbating, once a day or twice a day. It's like, well, how often do you have sex with your wife? Every 2 weeks. Well, it's like clearly that ratio is not a good one. And the reason why people do that is, first of all, it's a guaranteed orgasm. It's really easy. It's no mess, no fuss when you masturbate. A lot of men are masturbating to porn, and often the porn now is becoming, that's a whole nother discussion, but the porn is becoming something different than what they're actually engaging in. So it's very extreme, can have a lot of people, can have things that they would never be doing. And so actual real sex can't compare to the porn. So I sort of invoke what I call it's the only time I've ever named something after myself. I call it the Werner rule, which is that if you're masturbating a lot but not having enough sex with your partner, then what you do is after you have sex, you are allowed to masturbate as much as you want to your heart's content for a day or two afterwards. So that sort of gives you a double incentive.
Okay, hold on. I have to interrupt you a second. So give me a ratio. How many times a week should somebody is a good number for sex, and how many times a week for masturbation?
So the sex is the issue, and the masturbation is the fill-in. So if a man has a really high libido, if he's having enough sex with his partner and she or he is satisfied, he can masturbate as much as he wants. There's no limit. Sometimes I think it takes an obsessive quality, and then we have to wonder, why is someone spending so much time masturbating? If you're getting up to 3 and 4 times a day, why is that happening? Are you anxious? Are you obsessed? But, I have men who have great sex lives with their partners and are masturbating even on the same day that they're having sex, and that's fine. There's really no downside. To me, the key is you don't want to masturbate so much that you're not having enough sex with your partner, because it just decreases your interest. So it really is age dependent and couple dependent. So it's not really an absolute number. most people think other people are having a lot more sex than they are. I sort of say as a target, if you aim, again, it depends on the couple, so I can't do this generally, but if you aim for twice a week, and then you end up getting 3 to 5 times a month, that is an adequate sex life. That should be sort of your floor for really keeping sort of like a dynamic tension between
And
the
that's
two
for
of
any
you.
age.
Well, I would say that that's the goal. But we have tons of people, men, and women who come in and they're in their 70s and 80s, and they like, we're once a month, and we're really good with that. And you can see both of them are really happy. They have that sort of spark between them, and that's great. So I don't really think we can, um,
Okay.
come up with a number. But I do feel like if they're young and they're having sex once every 2 months, I know it's a problem. So it's like pornography. I know when it's a problem. I can't tell
I
you exactly
gotcha.
what it
I
is.
gotcha. And if you don't use it, you don't lose it.
Yeah, I think when people are not when men are not masturbating or having sex, then it's not good for their penis physiologically. It's not good for their prostate. So it's really important that they both stimulate and have good erections.
Perfect.
If we have a minute, I did want to just talk about, because I think this would be interesting for men. I want them to understand the difference between the PDE5 inhibitors, the Viagra, Levitra, Cialis, Stendrus, and a little bit about how they work. First of all, the Viagra is sildenafil and Cialis is tadalafil. Both of those are generic and they are unbelievably cheap right now. So if you go onto a website called GoodRx, which I have no affiliation with, you can get a coupon that gives you about 90 of the 20 milligram Cialis for about 70 cents each, and then you can get from Walmart or from Stop and Shop. So you don't need to go to these blue pill online or all these places that are popping up that are doing no evaluation. If you go to your doctor and you get a prescription, either it'll go through your plan or you can get it the real generics unbelievably cheaply. But when you use them, it's really important that you use them correctly. So for example, Viagra has to be taken on an empty stomach. If you take it with a full meal, it's just not going to work. And you always want to start with the maximum dose, which, for example, with Viagra, which is sildenafil, is 100 milligrams, and it peaks about an hour after you take it. So if you're going to use Viagra, sildenafil, you want to take 100 milligrams at least to start with, an hour before you're going to have sex on an empty stomach. Now, Cialis, which is tadalafil, um, you can take with food, but it doesn't kick in till 2 to 4 hours after you take it. So if you take it and then try to have sex 15 minutes later, you're not going to get a good erection. And then, of course, a lot of people call that the weekend drug because it's broken down so slowly. But at 18 hours, you'll only have half of what's in your system at 2 to 4 hours. And so it may not be active. And of course, at 36 hours, it's almost all gone. So it's really, it's important that you understand how fast it goes into your system and how fast it's broken down and whether you need to take it with food. And the most interesting, newest one on the block is what's called Stendra, which is still branded. And the cool thing about that is that it kicks in within about 15 to 30 minutes. So if you want to be a little bit more spontaneous, even though it's not as strong as the other ones, that one sort of, if you're sort of caught off guard or she initiates something or he initiates something, you can sort of use that and that'll kick in quite quickly. So it's important.
Yeah, and it sounds like that, the one that activates quicker, it sounds like there's something else going on there. That there is some kind of connection that the spontaneity that it's there, that the one that's an hour later or several hours later is more there's a difference, and there's a difference in sex when it's spontaneous, when that it's going to be spontaneous or when something's already happening.
Right. We really stress to people, though, that planned sex is better than no sex.
Right. I
and
gotcha.
It's only a little bit worse and maybe not than spontaneous sex. So, look, once you have, there's a magic period where you don't have any children and you're not using contraception, that everything is spontaneous, like all 9 times, depending on how fertile you are. But, once you get older, then you have the kids, then you have so it's like, and then when you're younger, then you're sneaking around making sure your parents, and then when you're older, you're having erection. It's like, so most of your life, if you want to have a good life, sex life, you're going to have to plan it. Get over that hurdle, is my personal feeling.
So now please tell everyone where they can find you, how they find you, and all of that stuff. Plug yourself now.
Got it. So my name, as you have is on the bottom. Our website is, we have several, but it's Mays Men's Health. And our offices are in Westchester County, which is north of the city, and we have an office literally right next to Grand Central. So a lot of people take Amtrak in and then literally walk 3 or 4 blocks to our office. We do have a cord blood bank called Mays Cord Blood, and that number is 914-683-0000. I was very proud of getting that number. The advantage is that it's just much more reasonable than the big banks, and also the highest quality because it's one of the public banks that does the processing for us. And we have the Women's Center and we have a sperm bank, and I do think we put things together in a very comprehensive and compassionate way. So,
well,
I love doing this.
And I can tell, and I'm sure we all can tell, and I feel like today we did the world some justice. So hold on for a second. You have my so here are my books. I'm going to put up a new one soon because I'm finished with the opioid book. So I have In Just One Afternoon Listening to the Hearts of Men, In Just One Afternoon Listening to the Hearts of Twins and Millennials. Then the opioid one will be being published very soon. And then soon thereafter will be Black Fathers. And they're all on Amazon, and they're both ebook and print. And they are all interviews, intimate interviews with the subjects of the book, and share everything imaginable. So, Michael, it was just so lovely to have you here, and I would love to have you come back again.
Thank you. Anytime. It was really a pleasure.
Yeah, because I'd like to have some
Happy New Year to everyone.
You too. I'd love to have some more conversations with you, and maybe in the future, if it's possible, I don't know, maybe somebody's willing to come on and talk about some personal experiences, if that's a possibility.
We do actually have a few patients like that who really want everyone to know that there's help out there.
So can we build a show around that too?
Yeah, let's give it a try.
I would love to. So we'll connect with you again because I think that would be really special.
Perfect.
So let's do that.
I look forward to it.
Absolutely.
Okay.
Thank you so much for being here, everyone.
Thanks so much.
Thank you. Thank you for being here with us today. I'm Nan, and everyone. We'll see you next week. Have a wonderful, wonderful week, and thank you so much for being here once again. Bye.
You are tuned to the Nissan Communications Network. If you tuned in too late, you can always watch each program in its entirety or download an MP3 audio file of it in the archives section at nissancommunications.com. Don't forget to subscribe to our YouTube channel, follow us on Twitter, and like us on Facebook. Sponsored by Telestream's Wirecast software, StreamingGear.com, Carolina Apparel, and DeltaForce.net.